Long et al. Did a peer mentoring study in African American veterans in a randomized controlled trial of 117 patients at the Philadelphia VA. These patients had to be diabetic with at least 2 diagnoses from the ICD-9. Um, the goal was to see how well that diabetes hemoglobin A1C could be controlled. There was a peer mentor group um, of peer mentors of similar age, race, and sex, where mentors received some training, were reimbursed, and had a goal of communicating at least once a month. There was a financial incentives group where patients could simply earn money for having an appropriate drop in hemoglobin A1C. Outcomes were measured at baseline and at 6-month intervals. There were safety measures to make sure nothing went wrong, where phone calls were made to make sure patients weren't having any adverse effects due to treatment or lack thereof. The only real adverse reactions were 1 patient in the usual care group and 1 in the financial incentives group, where there was a hospitalization and a case of passing out. As a result of the studies, it showed that peer mentoring had a significantly better outcome with a 1.07% drop of hemoglobin A1C relative to the control group. Financial incentives were inconclusive, and the study recommended that mentees might transition to mentor roles in the future to maintain results. For the second study, Tom et al. Did a randomized controlled trial of low-income patients in the San Francisco Bay Area. There were almost 300 patients that were randomly assigned to a peer mentoring group or usual care group, of which 103 were African American. They could be English or Spanish speaking, and inclusion was at the discretion of the primary care physician. The peer health group coaches had considerably more training than the first trial and were geared to make at least 2 calls per month or just 2 face-to-face meetings in a 6-month period. Their reimbursements were considerably higher, and they could have more than 1 mentee. In attrition, 16 control patients, 8 intervention patients, and 2 mentors did drop out of the study. As with the previous study, 1.07% drop of hemoglobin A1C in the peer coaching group, and there was only a 0.3% drop in the usual care group. 22% of peer mentor patients had a hemoglobin A1C of less than 7.5, and half of the patients in that group dropped by nearly 1%, compared to lower amounts by the usual care group. Now, in supportive nursing practice, we have the evidence that was provided before. The first study had an ideal African American age population, and the second study had a broader population but still had a mean age of 55. They were both randomized control trials, which were helpful, and they are certainly included in the evidence-based practice goals and health goals of on the national and local level. So this creates wonderful avenues for hospitals to explore, and as a result, I recommend the following intervention: a hospital-based peer mentor program aimed at African Americans who are about to be discharged for diabetes-related illness. These patients could be matched with a mentor prior to discharge and meet with them regularly for at least 6 months to see how well their hemoglobin A1C was controlled between discharge and that 6-month interval. Peer mentors would be trained and be symptom-controlled diabetes patients. This could be facilitated by the bedside RN and promoted by administration and nurse management. By setting it up in a hospital prior to discharge, it can provide for a smooth transition from inpatient to outpatient. If you have any questions, please feel free to post them on the discussion board.